And the last presentation will be done by Vyacheslav Ivanovich. Good afternoon. Thank you for your patience. We're a bit behind the schedule, but you know, it so happened that our presentation is related to the trials that are underway and that will show how the diagnosis of pancreatic tumors will change in the future, near future, and faraway future. Since we are not, not going to speak about the surgery, or not only about surgery, and the first part of the presentation will be made about the systemic treatment of pancreatic cancer, and I am responsible for surgical treatment. Of course, these topics are intermixed, but it would be interesting for you to hear how our scientific thought is developing in this area. And the first part of the presentation will be made by Julia. Please load my presentation, a different one. So let us start with chemotherapeutic part. I am a chemotherapist and would like to speak about the current trials in the field of pancreatic cancer. As we all know, pancreatic cancer can be divided into 4 categories, and this. And you know, but I have made them not very evident on this graph because the borders, you know, are very conditional between the degree of resection and between local and metastatic process. And that's where we mainly work. That's what we're focusing on. For all the time of clinical trials GAF existence, 2,412 studies for pancreatic cancer were published. So this is quite a large figure, because despite the fact that this is not a very frequent disease, but by the number of trials, it doesn't seed to more spreadable cancers like ovary cancer or gastric cancer. Of course, the leaders in the research activities are United States, Europe, and China. As to the last 5 years, out of all the trials that were registered for 5 years, we got 600 new trials, mainly on metastatic pancreatic cancer. But there are 62 papers on neoadjuvant and the peri-operational chemotherapy, and chemotherapy and radial therapy. So chemotherapy is an optimal approach in treating pancreatic cancer, and since 2005 we have known that chemical and radial therapy is better than just follow-up. Here you see the trials that were made in different years, and they all show that survival is gradually, but very slowly, increasing. And we understood that adjuvant chemotherapy is better than just follow-up, and adjuvant plus radial therapy. Chemo-radial therapy by GEM-CAP is similar. In the study a SPAC of 2010. Here you see two regions, 5-FeU-LV and gemcitabine, and CONCA-01 showed that gemcitabine is a very good scheme for adjuvant chemotherapy, and it became the standard of treatment for pancreatic cancer. But despite this combined treatment, a 5-year survival is only 30%. And as this diagram shows from Johns Hopkins Center, almost 77% of patients have a recurrence, and 23.5% show the recurrence in the first 6 months of treatment. 86% of these recurrences are remote metastases. In the first year is 50% of recurrences. It shows that probably we treat initially metastatic disease, because the earlier the recurrence takes place, the more frequently it is remote. The more time passes, after 2 years, the recurrences are becoming local. And that's where we're working now, and we look at the neoadjuvant approach. 128 trials, 37 trials were on the resectable pancreatic cancer.
We can split into the several categories, the approaches which are available. First is standard chemotherapy, which is also used in the metastatic disease. There are experimental options. They add on immuno to chemotherapy, immunological vaccines, PI3K inhibitors, etc. Chemoradiotherapy is not behind, but already there is a new approach which is called immunochemoradiotherapy, which is increased immunogenicity of the tumor. What do international guidelines tell us? According to NCCN, in case of resectable pancreatic cancer, we can select neoadjuvant therapy, particularly in high-risk patients. What does it include? So, high risk, what does it mean? So, this is unclear findings on CT, which cannot be assessed properly. A high level of CA-99 post-treatment, big tumor, and increased lymph nodes. In fact, we have several trials which show the advantages of neoadjuvant chemotherapy in resectable process. You can appreciate the meta-analysis of 1,500 patients by Ali Mokdad and the group, and they show the advantages in both survival in overall and relapse-free survival. This is the new Japanese publication of beginning of 2019, comparing standard option, which is surgery, and then adjuvant S1, which is fluoropyrimidine of new generation, fluoropyrimidine of new generation, or the approach of perioperative gemcitabine plus S1. According to the results, they increased overall survival by 10 months with pretty low toxicity at the same time. And this is the first randomized trial, PrEP02J-SAP05, by resectable pancreatic cancer. Before that, we had the Dutch study called PrioPanc1 from 2018, where they included not only resectable but also borderline resectable pancreatic patients. So the first arm, that was surgery and standard adjuvant chemotherapy by gemcitabine, and also chemoradiotherapy pre-op, and then adjuvant chemotherapy post-op. The results of PrioPanc1 were quite optimistic. They still show that relapse-free survival demonstrated some advantages, although in the overall survival there was just a trend and they did not reach statistical significant difference, but still R0 resection was almost doubled, 63 versus 31%. Besides, there are active trials, phase 2-3 ongoing, which we are expecting to show the results in the near future. So they study all the regimens that we are using for the metastatic disease in different combinations with different order of administration, but these trials are about to be published. So chemoradiotherapy in neoadjuvant option is not so frequent option, but nevertheless, we can appreciate some interesting options in combination with immunotherapy like pembrolizumab, durvalumab number 3, together with chemoradiotherapy. By now, the standard of treatment is still surgery with further adjuvant chemotherapy, starting from stage 1. We have 3 main one, which is S1, or the other name is Teisuno, which is standard in Japan, and in all other countries is modified FOLFIRINOX or gemcitabine plus minus capecitabine for 6 months. But the biggest challenge here is R0 rate is reached in such approach almost in 70% of cases. But the scheduled chemotherapy is received only by 50% of the patients. Not all of them get it. In adjuvant chemotherapy S1, SPAC1 study comparing gemcitabine versus S1, they got really great results, twice higher overall and relapse-free survival median. But in our country and in majority of European countries, they yet do not routinely this option because it was not studied on the European population. SPAC4. This is the study which allowed to register gemcitabine and capecitabine, and it used to be the standard of treatment for about 1.5 years. What were the results? So they compared here gemcitabine as a mono and gemcap, 6 cycles, and you know that both of them belong to one group of antimetabolites. Speaking about overall survival, this is quite humble difference of about 2.5 months. And they did not get any difference in relapse-free survival at all, and no difference in 2-year survival. Besides, the relapse rate appeared to be completely the same. Well, in fact, this study creates lots of questions. Why we got changes in overall survival without any changes of relapse-free survival? And still there are questions to the study and limitations. The chemotherapy regimen itself, so it benefits in survival, quite doubtful, because this regimen came from Cunningham study of 2009, where they tried this regimen on metastatic patients. At that time, they did not show the difference in overall survival, but there was humble difference in relapse-free survival. And after one more meta-analysis, this regimen came into the practice of some chemotherapists, but currently SPAC4 clearly shows that in this case the efficacy of the regimen is still doubtful. Besides, the diagnostic approaches are not clear because CT was performed 3 months before the randomization, and they did not take into consideration the CA99 level. So, in fact, we don't know how many metastatic patients were treated in the study, because the pre-op level SA99 was not detected in about 50% of the patients, and the median of this parameter was 550. 150 corrects the speaker, which is quite high level. Post-op SA99 did not detect in about 100 patients, and the investigations themselves say that in 70% of cases, those patients who had level of SA99 higher than 92 had the survival of 13 months, which is quite comparable to metastatic patients. Also, those patients who were enrolled into the study, they were patients with initially unfavorable prognosis. That means 60% of R1 resection and 80% of N positive. And we do not have clear data how frequently they examine these patients, once in 6 months, once in 3 months. So we have no this data available. So frankly speaking, there are some limitations, and we have some open questions towards this study. Now, the breakthrough study, Prodigy 24, where for the first time they showed greatest advantage of modified FOLFIRINOX versus standard gemcitabine 6 cycles. This is more serious design, and probably for the first time we got survival of 54.5 months, which is 4.5 years of life. And the difference in relapse-free survival is also twice high in this regimen. We should not forget that toxicity is still very high, and not every patient managed to tolerate this chemotherapeutical scheme. And definitely frail patients after difficult surgery, not all will tolerate and not all will be able to get it. And besides, in the study they included only patients with ECOG status 0 or 1. What are our expectations from adjuvant chemotherapy? So these are 3 main studies which are currently registered on clinicaltrials.gov, but we are eagerly waiting APACT results, which shows the difference in survival in gemcitabine as a mono or gemcitabine in combination with Abraxane, which is the second most frequently used scheme in metastatic disease. I understand that here the majority of you are surgeons, but still I should comment on this evolution of conservative treatment and the importance of metastatic pancreatic cancer treatments. All the regimens, in fact, which are used for neoadjuvant option now, they all came from first metastatic studies. We chemotherapists, in fact, from 2013 had almost nothing, no breakthroughs in treatment. So in 2013 we had Abraxane with gemcitabine, and after all, no breakthroughs. Right now, in our hand, we have 2 main options, FOLFIRINOX and Abraxane plus gemcitabine, which we are combining. But still, there are lots of controversy. Which is most preferable, which is less toxic? But these 2 regimens were never compared head-to-head. In 2018, the group of Kim published retrospective analysis of survival after these 2 regimens. Upon the results, we have no difference in survival between FFX and Abraxane plus gemcitabine. In 2016, they published a new study, which is Napoli-1 trial, and they looked at new therapeutical option, which is non-liposomal irinotecan. Its advantage that non-liposomal irinotecan, so this is irinotecan binded to liposome, and it does not convert its active agents in blood, but there is a very high accumulation in the tumor tissue specifically. So investigated wanted to compare licavarine with toruracil, fluorouracil, and new agents with non-liposomal irinotecan with fluorouracil. So there is a difference in overall survival, progression-free survival. That was statistically significant difference, although this therapeutical agent is not yet used in bigger practice in our country and in Europe, and it was never compared to standard irinotecan, and we never know whether the result will be the same or not. Right now, there are new therapeutical approaches to the treatment of metastatic pancreatic cancer. These are such groups of drugs like modifiers of stromal tumors, targeted treatments for patients with BRCA mutations, immunotherapy, and metabolism-targeted treatments, and the combination of all mentioned above. In fact, the studies of new targets are carried out very actively. Only since December 2015 up to May 2015, in the clinical trials, I found 47 candidates which did not show any efficacy in the clinical trials. Speaking about pancreatic cancer immunotherapy options, well, at the moment, this is a very fashionable trend for all the nosologists, but yet, pancreatic cancer is not immunogenic tumor, and this is low mutational load. This is deficiency of T lymphocytes in the tumor, and the availability of immunosuppressive cells and cytokines, and high pressure, and very dense stroma. Why pancreatic cancer is not immunogenic is very clear. MSI high, which is predictive marker of microsatellite instability of high grade, is very rarely seen. Nevertheless, there were some studies tried to use durvalumab, tremelimumab, using checkpoint inhibitors and CTLA-4 inhibitors without the link to the high grade of microsatellite instability. So these are studies of durvalumab and tremelimumab. They didn't show any effect on overall or relapse-free survival without that marker. Nevertheless, ASC currently tells us that MSI can be measured in all patients with metastatic pancreatic cancers routinely. The grounds for these guidelines is the study which included patients with few types of tumors and high grade of microsatellite instability. Well, there were 8 patients with pancreatic cancer included, and all of them demonstrated response to treatment. That is why in ASCA guidelines we see pembrolizumab, which is recommendation 3.2 and 3.1, which can be used in patients. In order to overcome this low efficacy of immunotherapy, the investigators try to make further attempts to treat patients without MSI high, which is done by combination with chemotherapy, radiotherapy, vaccines, agonists of CD40, anti-CXCR4, etc. So that's the main list of trials currently ongoing, where they try to use combined options with immunotherapy. Besides, in case of pancreatic tumors, there could be quite rare marker, which is BRCA1/2 mutations. In general population, the level is very low. The incidence is about 4 to 6%. But the highest incidence rate is on Ashkenazi Jewish patients, which is 13.7%. What can we do if patient is carrier of BRCA? So we can use Parp inhibitors and platinum-based treatments. Parp inhibitors, these are inhibitors of polyadenosine ribose phosphate, which is participating in the restoration of DNA threads. So when this enzyme is inhibited in tumor cells that carry BRCA mutation, this process is not going. Platinum-based treatments, well, of course, the mechanism plays a role. This is destruction of DNA links. So currently it's phase 3 study, which comparing gemcitabine cisplatin as a priority in case of BRCA mutation with add-on of Parp inhibitors. Well, we have just the pilot phase data available, and the response rate, well, responses in all the patients, in all 17 patients, who are carrying BRCA mutation. Besides, they studied the influence of Parp inhibitors in the maintenance after the effect of chemotherapy was reached. So Parp inhibitor studies are also multiple with different regimens of chemotherapy, and I think it is very prospective for further studies. Besides, there is a new approach currently studied, which can be used exclusively for pancreatic cancers. This is modification of tumor stroma. As in pancreas, as we know, stroma is desmoplastic, and it limits the drug delivery. And also so-called immunological desert, which is also due to the tumor stroma. Currently, they try to use the recombinant human hyaluronidase, agonists of CD40, vitamin D analogs, kinase inhibitors, but probably the most prevalent here are the studies of hyaluronidase with chemotherapy. And here you can appreciate this data of phase 3 study, which showed very good difference in survival. Wrapping up, I would like to say that neoadjuvant chemotherapy is a new and very prospective approach to the treatment of the resectable and borderline resectable pancreatic cancers. So the breakthrough, definitely using adjuvant regimen, modified FOLFIRINOX. Nevertheless, the standard chemotherapy in the metastatic cancer still leads to minor improvement of survival, and new agents that can be considered as prospective. These are Parp inhibitors in BRCA and immunotherapy in MSI high, and possibly immunotherapy without MSI high, but with combination with chemotherapy. And probably the most active Parp inhibitors, chemotherapy, is exactly the method of treatment which improves the results at any stage of pancreatic cancer. Neoadjuvant approach as a priority, and I'm pretty sure we can expect one day neoadjuvant becomes a new standard for borderline resectable and almost a must in resectable options. Thank you very much for your attention. Thank you very much, Julia. So my part is mainly devoted to the surgical approaches. And the method I was using, these are keywords plus details in clinical trial gov, and these keywords shown here found 1,067 trials, and I will speak about all of them in detail. I'm joking. So the first are the studies on the technical surgical issues of pancreatic surgery. We have to say that there are few RCTs about that. Please appreciate some of the trials, that means 2 of them on distal cancers, pancreatic cancers coming from China. So these are new champions on productivity in surgery, in pancreatic surgery. For example, the hospital I recently came from makes 900 pancreatic resections a year. It appeared to be that there are very many hospitals with such productivity, with such performance, and I would say Chinese are the real champions in the patient enrollment and the data collection, because there are hospitals that report on about 1,500 radical surgeries in pancreatic cancers for 2 years. What clinics are doing for the whole lifespan, they just get within 2, maximum 3 years. And it will definitely change dramatically our understanding in the near future. Also, these are technical studies, technical issue studies, and then some issues that we used to believe to be already studied, again, restudied. Early drains, open drains, or using pilorous ring or pilorous sparing resections, 1 loop, 2 loops. Actually, it seems we know all these answers, but the time is changing, approaches are changing, and possibly we will get new results after these trials at a new level. Also, there are studies on the methods of selection and prediction in pancreatic cancers. If you appreciate the institutions that are carrying them out, so these are high-volume centers like Memorial Sloan Kettering from New York, or Mayo Clinic, or Reims Clinic in France. So we should not forget that biology is the key, and the selection of cases is a queen. So selection methods are still being designed by high-volume centers. Speaking about vaccines in pancreatic cancer, these are the studies which mainly characterize the level of hospital, and one Chinese clinic also carried out this Chinese multi-center study. Also, the analysis of treatment efficacy and standardization of surgery and post-op management of the patient. Here I would like to draw your attention to the Korean study, which came back to the discussion of high-dose pancreatic enzyme replacement therapy after pancreaduodenal resection. Which is better, classical or extended? Biomarker studies. This is also one of the topics which is actively being designed, explored for the prediction and the patient selection, because in fact selection is a queen. I wonder how many studies are carried out on the radiofrequency ablation assessments in the pancreatic cancer treatment. So 2 studies on the locally advanced pancreatic cancers, and also there is another one in neuroendocrinic and cystic tumor completed.
Интересно, что клиника МБИО затем...
Your clinic started a very large trial on ablation of cystic tumors of pancreas with the help of the alcohol solution. A very interesting test is made by the U.S. Institute of Health on the resection of pancreas with in patients with von Hippel-Lindau, and they found 340 patients, which is a very high figure, and that will allow us to get a new picture of the problem. As to the neoadjuvant chemotherapy for the resectable pancreatic cancer, you saw this is the first part of the endless list of trials that are made in high volume clinics globally. And here you see the list of these centers, of these sites, and this is the second part of the list containing 36 trials, and that makes us think that very soon, as John Cameron has already said today, resectable pancreatic cancer will be treated by neoadjuvant chemotherapy. As to mini-invasive technologies in the pancreatic cancer treatment, this is a very serious technical moment, and we cannot but agree with Professor Cameron that a significant part of pancreatic resections will be made by mini-invasive methods. However, despite the fact that meta-analysis and different trials say that there is a non-inferiority, so they are not inferior to open surgery, there are still questions that are raised by such trials as comparison of mini-invasive and open surgeries on the rectum, and mini-invasive and open surgeries for cervical cancer. They showed negative results for mini-invasive operations, and that resulted in the fact that many U.S. hospitals reduced the number of laparoscopic invasions. So the reason is not yet clear. It is being studied, and in order to assess the result of mini-invasive operations, we need randomized controlled trials with a long follow-up. And of course, also we needed to speak about very important trial that compared laparoscopic and open pancreatic resections. It was done. It's LEPAD-2, and was done by the Dutch Pancreatic Cancer Group, who are very well known in our world. And this test was based on the good experience of introducing laparoscopic methods for the resection of distal areas of the pancreas. And a decision was made to make a comparative trial of open and laparoscopic resections. 4 sites took part in the trial. Here you see the selection criteria. The main purpose of the trial, so the main purpose of the trial and the criteria for selecting surgeons. Here you see the design of the trial that shows a one-to-one randomization. This is a slide characterizing patients that were taking part in both groups and endpoints. it was assumed that these are the assumed results. So 130 patients were recruited, and it was assumed that the laparoscopic operation would be shorter. This is the slide of monitoring patients. 99 patients out of 136 received surgery. So the trial was discontinued for ethical reasons. These are the results that were found. It's a 5-fold increase of lethality in laparoscopic group due to surgical complications. These are the data that characterize the situation, and it is interesting to see that one of the methods of selecting patients was to exclusion of vascular invasion. Nevertheless, 12% of patients received a vascular resection. As to other indicators, the groups were not different. And by the level of insufficient anastomosis. They were not different by the level of severe complications. The lethality was 5 times higher in the group of laparoscopic operations. So there were also 2 patients that died of cancer in the following 90 days, and that also arises questions. These are the causes for mortality of patients. It is hemorrhage, twice delayed, intraoperative damage of the vessel and fistula. The authors themselves write that the trial was limited by the fact that it was taking place in the conditions of the learning curve. And here you see a conclusion that there is no difference in time to functional recovery between LPD and OPD, but there is a difference in lethality due to surgical complications. And it is quite natural that it is difficult not to notice such a trial because it is unique, and the primary results of mini-invasive operations are not known in most articles published by other doctors. And it also puts a question of the operational safety and make an informal conclusions that a surgeon that makes a laparoscopic operation on the learning curve is dangerous for the patient. And in the period of mastering this laparoscopic approach, the surgeon is more dangerous for the patient than when mastering the open surgery. It raises a very important issue, whether the patient is to be informed about it or not. If we inform the patient about the reduction of the safety level in laparoscopic approach, then we reduce the level of safety. And how can a surgeon undergo the learning curve is not clear. If no one in the clinic has undergone this learning curve of 60 laparoscopic invasions, what is to be done? Probably we shouldn't inform the patients and risk, but then we risk their safety, put their safety at risk. And on the right, you see the landscape that shows the number of surgeons who had undergone a learning curve of laparoscopic invasions in our country. On the one hand, it is a matter of pride, but it makes us think. And we may understand why the learning curve is dangerous for the patient. And also the absence or deficit of the mentor is also important. It has been mentioned by Professor Khatькov today. We have seen reasons for which surgeons introduce this operation much rarer than others. Probably it is the reason why in Johns Hopkins laparoscopic surgery is second to robotic, in making resections. And robot-assisted resection in the period of learning curve is safer than laparoscopic. That's the that is proven by Pittsburgh experience. And one of the reasons is also simulation, which is not described for laparoscopic resection. I would like John Cameron to look at this slide. And this wonderful phrase has been mentioned, was said in 2012 when I was visiting the Johns Hopkins clinic. He said that he said 1,000 operations from the right and 1,000 from the left. That means he's helped 1,000 times. And which of our surgeons helped 1,000 times? 50 times at least. No one. This is my assumption, but I think it is quite meaningful. And that shows the level of safety of laparoscopic and open surgery. And the patient and the surgeon must know that the surgeon making a laparoscopic invasion on the learning curve is dangerous for the patient, more dangerous than for when he's mastering open surgery. And it is confirmed in many high-volume centers that make a large number of mini-invasive operations. For example, I was in China, I saw it. Out of 900 resections of pancreas, 250 operations are robot-assisted, and that none of these operations are meant for patients with bordering pancreatic cancer. So we may say that randomized clinical trials are required to assess groups without complications, with severe complications, and moderate complications. That will allow us to understand the importance of this learning curve in the development of our industry. So I think it is must be done now, because safety first is our principle. Thank you for your attention. I'm very happy that Vyacheslav Ivanovich in his presentation devoted up-to-date clinical. So he paid a lot of attention to the experience of separate clinics, and that is really great. That will be a very good transition. After a break, we will pass over to the discussion. We are behind the schedule, but we have time until 3 o'clock. And I think a 15-minute break will be very timely. And then we will organize a very interesting discussion.